Okay, we're back to plan a lower arch. This one on a patient named Connor, who's a double all-on-4 with a class 3 bite that we're going to kind of jump the bite. So that means we need to be cognizant when we plan the implants that we can be a little more lingual than maybe we typically would, because we're actually going to bring the lower teeth back a little bit and bring the upper teeth out. So nonetheless, we're right here at AIS 5.4 again with Acteon. And I've just opened it, and I'm going to start by bringing in Connor's lower model. We're not going to bother with his upper model since we're just doing the lower on this case, but the upper has also been planned. And so essentially what this is his upper, this is his lower model, okay? And we've already planned the upper and lower together. So I'm just going to bring in the lower wax up, and we're going to plan on that. We're going to do our assisted bring in very fast on this one. When there's that many teeth, it's usually pretty predictable. So we can confirm that we like how everything lines up. We'll hit apply, and now that we have that, we can bring in the wax up. So we're going to bring that in the same as the anatomy, and just navigate to my file here. Okay, so here's his wax up. All right, we can kind of, there we go. We can see it now. Okay, so that's our ideal wax up. With the class 3 bite, his lower jaw is a little bit shifted to one side too. So you'll notice the teeth look a little bit canted. His originals were canted, and so we're fixing that with the new ones. So you can kind of appreciate that. We're going to fix that lower cant. Okay, let's go ahead and draw our mandibular curve. We'll let the AI do this, and then we'll also let the AI pick and find the nerves as well. And the advantage of the newer software, and like I said, this software comes packaged with an Acteon CBCT, the new 5.4. So it's going to give us a really nice, it automatically aligns the arch kind of like to the occlusal plane, it follows the nerve very nicely. So we're going to hit next, and then we're in the nerve drawing. We're just going to hit detect nerves. We'll let it do that too. And then we'll also segment out the mandible like we did on the maxillary case. And then we'll have all the models we need. We'll have the wax up model and the segmented bone model. And of course, we'll have the nerves mapped and that sort of stuff too. Okay, so it's segmenting out the nerves. Now, you can still do this manually. You know, if it's still faster for you, or you're just doing one side and you just want to quickly plug a nerve in there, you can still do that completely manually. Okay, so our nerves have been mapped. We're going to skip the teeth setup. If you want to do a wax up yourself, of course, we had the lab do it and brought it in. This would be the plane that you do it in, is the teeth wax up setup. So we're going to jump right down to segmentation. Let's go ahead and segment this bone. We're going to not include the teeth, and we're going to segment out the mandible. This will allow us to do what we did earlier, where we can make our alveo model, essentially, that we can print, or we can just have up on the screen so that we can kind of gauge, because everything looks different once the teeth are out and the alveo has been done. Now the socket holes are in different areas. It's nice to have that physical model that's not covered in blood during the surgery, that you can make quick reference to, make quick measurements on. For instance, you might measure the socket of what's left and go in the mouth and say, okay, I actually have 2 more millimeters of alveo I need to do. And so there's quick references you can do that way. So here's our mandible. Really nice green color it gave us today. Okay, we're going to go next step. If we need to make any adjustments, we can. We'll just go ahead and finalize it. And here's what we have. We have the rendering, which is a really nice, clean rendering. We've got our cool green bone. And I'm just going to switch to white. We have his original kind of orangish pink teeth, and then our wax up is in white, which let's just go ahead and change that to SPG blue. Okay, so we can turn off the rendering now. This is all more accurate than the rendering, and we can even turn off his model. Okay, so here's his bone with no teeth, and then the teeth we want to put in there. Cool, so we've done our wax up. This is all based off of the upper wax up, so these teeth are meant to align to the upper. That's been planned. But now we can see we need to do a decent amount of alveoloplasty. Remember our rules. The shush photo, and Connor didn't have much of a lower lip mobility, so that's irrelevant. We're going to get at least 15 millimeters from these teeth. So if we were to go to this panel curve and go down 15, you can see that's what the wax up is. You asked the lab to give me a 15 millimeter tall wax up. So each one of these teeth is cut off at 15. So that's my minimum alveo plane right there. The implants have to be at least at the base of these blue teeth, okay? But then also we need to have enough bone thickness or width to house implants, biologically. So that's usually on the mandible. Our main determinant is the anterior mandible bone width. Okay, so let's go ahead and make our pano nice and large. And we'll go straight to the posterior where we start. We find the mental foramen. I go right above it, and then I kick out the angle here. So my goal is to enter my implant superior to the mental and immediately angle away from it. So we'll call this one number 20. Plenty of bone here. Nice thick plates. Don't make the mistake of trying to plant it in a thick plate. You're just not going to be able to pull that off. So plant it right in the cancellous bone here. It's going to be very easy to do because the conner has very thick bone on both sides. So your drills are just going to kind of naturally going to want to go here. And because our wax up is exactly 15, it's a really nice reference, so we can just make sure our implant is planted at least deep enough to clear the blue wax up part. You can see it on this side too. Okay, it's giving me a bit of an error because we were too close to the nerve there. All right, so now we're doing this. Let's bring in a angled abutment, so a 30-degree abutment, and we can go with our 16 millimeter length implant. Okay, and now I can toggle. Let's turn off our guide sleeves. This is our angled abutment, and you can see we're able to spin the timing around, right? Let's actually make the bone a little transparent so we can see what we're doing in space here. We can spin the implant around until, just to make sure that this positioning has a timing element that'll allow us to put this in a good access hole location. Surgically, you're going to be the one who chooses the final timing. I'm just making sure that as planned in space, there's an ideal timing available to me. Okay, so we're going to come out second premolar there. We're avoiding the nerve. That all looks great. We're going to go straight over to the other side, find the nerve, go right above it, 30 degrees. Ideally the same implant just for simplicity. Okay. Let's see how that looks. Good, good, good. I'm going to turn off my sleeves. The reason the implants are red is because I have a guide sleeve turned on, and it's telling me the guide sleeve is going to bump into his teeth. So now they're green, means go. Okay, let's go ahead and get our timing corrected here. Okay, so there we go. We can get between the two premolars. Maybe I can cheat back a little bit more. Get a little bit closer to that nerve. And if at any one point we can come up here and we can spin around the implant, and we'll see the pink nerve. There it is. Okay, so we're staying nice and away from it. I'm a little bit close for comfort here. Let me just back off a little bit more. So we won't have as much AP spread on conner's right. Now we're going to look in the back. Once we have these front 4 implants planned, we're going to look in the back and see if there's any space for us to put an implant in the back. Let's go to the lateral incisor next. That's our typical spot. Go to the lateral incisor and look for a spot to put one straight up and down. Maybe a little shorter. How about a 4x13? Go with a straight abutment. And it got me a little bit squirrely here. Here we go. Okay, get us back in the right spot. Okay, so now we got plenty of space. 15 is the bottom of this blue, but we need to get down into where there's good bone width. So that's about here. So we're going to have more alveo in the front, closer to 17, 18 than necessarily you need for restorative space, but you need it for biology. Very typical setup for the anterior to have that. And we're just going to kind of polish it back, okay? Let's go ahead and lean this back a little bit so we have we'll just lean it right against the lingual plate. That'll be a nice reference for us. If we lean it right against the lingual plate, we'll be coming out right behind in the cingulum area of those teeth. That'll be perfect. Let's jump right over to 23. Same thing, go down to where there's enough width. Oftentimes that's below the sockets of the teeth. In conner's case, we can actually place this with a little bit of socket left. So what we might do is we might reference, okay, we're going to have about 5 millimeters of socket left, and we're going to be placing the implant, 1.5 millimeters deep. But that's a reference we can know in the mouth that we can easily reference. Okay, we'll turn off our guide sleeves here too. Let me turn off the guide sleeve here. Okay, So here's our 4 planned implants. Let's get this one a little bit more leaning back. Because remember, we're bringing the teeth back because he's class 3, right? So we have to kind of cheat backwards. So that looks good. We can turn on our implant angles. We're within 10 degrees everywhere here. That's phenomenal. So if we wanted to on this, on this number 28, we can maybe even lean it back a little bit more, and we'd be totally fine and have a little bit better access channel, a little bit more AP spread right there. Okay. Now, we're happy with the front 4, but Connor's a young guy, big guy. He's used to having a lot of teeth, and we have really good spread on the top. So let's see if we can give some posterior support. So let's go back into the molar region. And the typical spot that I'll look is the mesial roots. They tend to be a little bit straighter. Not necessarily in his case, but they tend to be a little bit more axially angulated. You don't want to go too close to these angled abutments because what you'll end up struggling with is the surgery to put this in and then this one straight up and down. There's not that much of a difference in space, and you end up restoratively kind of making yourself working in too small of a space. So let's go back to the second molar area. And something shorter, for instance, like a 4x8, and we can put a straight abutment on it. And we can even cheat kind of backwards a little bit. There's usually a good, if there is no molar, but there's a second molar, that bone in front of the leaning second molar tends to be pretty good. It's almost like it snowplows the bone up. So there's usually a good amount of bone right here. And you can see that's exactly what we have. We can even do a 10 millimeter. We're still far enough away from the nerve. And so we're right in front. And this is easy to find in the mouth because you're just going to take a lindamen or some sort of sharp lance and cut into that bone that's in front of the mesial root of the second molar. And we can see kind of where that puts us, where that angle would be. So it gives us another tooth. And I forgot to turn the sleeve off on this one too. Let me just go ahead and do that. Okay, now can we cheat even further back? Yeah, I think we could. So you could go through the mesial root like this and bisect it. And that gives you a little bit more distance between that and the other one. So that's a good spot for that. Let's go back the other side. Looking at the distal root of number 19. And if we zoom out, we can see we still have our 15. There's our wax up. 10 millimeter implant. Nerves nice and far away. So whenever you can use an easy marker like a root, like a distal root, go for it. Keep it simple. And now we're going to correct our angles. Tilt it back a little bit. Great. Okay, so just starting in the distal root, but keeping everything relatively upright. We can even scooch this a little bit this way. Okay. So that might be a very nice preliminary plan for a lower all-on 6. We always plan the all-on 4. Like I said, we don't do more than 4 implants between the nerves. We don't do more than 4 implants between the sinuses. There's always extenuating circumstances where maybe one didn't torque out, so you add a 5th or a 6th to do so. But the plan is always 4 intraforaminal or intrasinus. And then when you can, get some posterior support in the molar region, whether it's a palatal root on the maxilla or a root socket like this in the lower.